There are different types of surgery that we can do. Broad terms, there is what we call malabsorptive surgery, where you eat what you like, it doesn't get absorbed, and it comes out the other end in a rather unpleasant state. We don't do that surgery in our practice because you can end up with major problems with malnutrition, protein depletion, and problems with a lot of vitamin deficiencies. So we prefer to do what has been called restrictive surgery, but the reality is that it does work on the brain. In this picture here, you can see the three types of surgery that we offer. All of these operations are done telescopically, i.e. through keyholes, the biggest cut being some 10 to 15 millimeters. And most patients are home by 3 days after the surgery. The first operation is the Roux-en-Y gastric bypass. The second one is the sleeve gastrectomy, and the last one is the laparoscopic adjustable gastric banding. With the gastric bypass, I create a small tube of stomach, so instead of having your normal stomach this large, you end up with a stomach that is that large. This is connected onto a piece of small bowel, and the food then goes straight through this little tube of stomach into the small bowel. Downstream, it joins up with the normal flow of acid and enzymes from the stomach and the pancreatic juice and bile that comes in at this point down here. The food then mixes with that and normal digestion occurs. The important advantages of this operation is that it produces almost consistently good weight loss in the first 6 months. It can also produce almost instant cure of type 2 diabetes. And if patients haven't been on vast amounts of insulin and have been diabetic for a short time, they will often leave hospital requiring no more insulin. The disadvantage of this is that it is a more major operation, and we do tend to consider it permanent. There is cutting and stapling, and therefore there are risks of bleeding and leakage. The other thing is that we are actually bypassing the bit of the small bowel that is important in terms of absorbing calcium, iron, and some of the other vitamins, and we therefore would recommend that people that have this surgery do take vitamin supplements orally for the rest of their lives. The remaining stomach is firmly fixed in place. People do get the impression that it's flapping around in the breeze, but it is well held down by blood vessels. It still has functions and is still useful. The sleeve gastrectomy is a newer operation, and it was originally designed just to be the beginning part of one of the other more major operations. They found that when they tried to do the more major operations in people telescopically, there was an unacceptably high death rate. And so they would actually get people to lose weight with this part of the operation and then change them over. What they found, though, was that some people lost an adequate amount of weight and didn't need another operation. And the concept of using it as a primary obesity surgery then became reasonably popular, and it has taken off around the world. Because it's new, we can't guarantee what the long-term results are, but there are some good results coming back that are now 5 years out, and over that time we've altered a number of aspects of the operation, so it should be getting better and better. This really is an irreversible operation. Once it's done, there's no way you can put the stomach back. It does have advantages over the gastric bypass in that you don't have any small bowel replumbing, and theoretically there shouldn't be the same malabsorption problems, but people still do need to take supplements after this operation. The other problem is that it can cause significant reflux, and if people have already got reflux, we wouldn't tend to recommend this surgery. The other problem with it is you still have long staple lines that can bleed and leak, and if that does occur, even though it is rare, it can be a major problem. The gastric band has been around for the last 20 years now. It involves putting a small silicone ring around the top of the stomach, just below where the gullet joins into the stomach. There is a little balloon on the inside of that is connected via a long tubing to a port that sits underneath the skin on the muscle layer, and we are able to access that and adjust the amount of fluid in that balloon so that we can get the desired effect that we want with the operation. This operation is not quite so obvious in the way that it works because the food still goes down and goes through the band, but having the pressure of the band there does seem to feed back via nerves onto the brain and tell the brain you're full, you're not as hungry. And that is a little bit of a mystery to us, but it can be very effective as a weight loss operation. The main advantage of this operation is it's a one-night stay. It's definitely the safest of the operations. We're not cutting or removing anything, and therefore there is no great risk of bleeding or leakage. With the gastric band, a lot more follow-up is required because we have to adjust the amount of fluid, and what we're aiming for is to have just the right amount of fluid that you can eat slowly, carefully and mindfully and feel full early on, but not be able to eat too much, but not have the band so tight that it actually makes you vomit. Patients with a well-adjusted band should not be vomiting. If someone that you know has had a band and is vomiting, it is too tight and they haven't learned to eat to meet the requirements of the band. So why would you choose one operation over another? Safety is obviously one of the features, but the other thing that does matter to people is how effective is the operation. Now in this slide we can see our results with the band and the bypass. We haven't done enough sleeves long enough to actually be able to produce a graph, but it's in between these two lines. You can see that this is the percent excess weight loss. That means if you've got an ideal weight that is corresponding to a body mass index of 25, anything over that is your excess weight. So if you weigh 100 kilograms and your ideal body weight was 70 kilograms, you've got 30 kilograms of excess weight. This graph shows how much of that excess weight is lost with people with the two operations. As you can see, the bypass produces on average an excess weight loss of 81.5% at 1 year, 82.5% at 2 years, and then gradually there is some weight regain. The band is not quite so dramatic, and the weight loss is around 50% at 1 year and 60% at 2 years, but it does tend to persist with much less tendency to get weight regain later on. And as I say, the sleeve will be somewhere between the two. It is important that people realize that there are potential complications with the surgery. We actually haven't had any deaths within 30 days of the surgery or deaths that are related to the actual operation itself, but there certainly are reports overseas and a few in New Zealand of deaths related to obesity surgery. The main deaths are related to blood clots that form in the legs and travel to the lungs, and in relation to the leaks that can occur when we're doing cutting and stapling operations. There is also a risk when we're doing telescopic surgery around this area of damaging the other organs in the area, in particular the spleen and the liver. If that happens, there can be significant bleeding or the spleen need to be removed. With the banding operation, very low risk of bleeding. With the bypass operation, the risk of transfusion is about 1%, but out of 1,300 patients, I've only had to take 2 patients back to theatre for bleeding. I like to sleep at night. I'd make a big effort to make sure that people don't have anything that's going to bleed late at night. The other risk with the bypass in particular is that there can be a narrowing at the join between the stomach and the small bowel. If this occurs, we actually have to, while you're asleep, put a gastroscope down and blow a balloon up in that joint to spread it out, and that will fix the problem. That occurs in about 3% of people, but as I have to pay for that dilatation, I again will do my best to make sure you don't need it. Leaks after the gastric bypass and the sleeve are a major problem. It's not good to have stomach content or small bowel content floating free around the abdominal cavity. Again, in my 1300 bypass patients, we have had 2 leaks. Both of those patients have recovered well, and both would still go through the whole surgery again, but they certainly gave me my grey hair. As mentioned before, we actually do cause vitamin malabsorption, and if people do not take the supplements, they can get significant vitamin deficiencies, and sometimes these are irreversible. That is definitely the patient's responsibility though. When we're doing a join between the stomach and the small bowel, there is a potential to get ulcers, and we make a big point of telling people that they have to take anti-ulcer treatment if they start taking any medication that can actually cause ulcers in a normal stomach. The other potential problem with the bypass is we are doing replumbing. We are bringing bowel up and we are dividing and creating spaces that never existed before. We now close all those spaces, but we have had one late death where someone did twist the bowel underneath and it wasn't recognized at their local hospital. That is a preventable death, and we always encourage our patients to ring us if they are having severe pain. Fortunately, it is very rare now that we are closing up all these spaces. With the band, because it is a physical object that shouldn't normally be there, there are other potential complications. The little reservoir that sits under the skin can tilt or twist or break, again very rare, but if that happens, we will replace it free of charge for you, as we regard it as a technical complication. The other complication that people have often talked about with the band is the fact that the stomach can protrude up through the band, and we end up with a situation where people acutely can't swallow. In our experience, that has always been when people have had the band adjusted too tightly and they can't swallow, are regurgitating frequently. In other words, again, it's a self-inflicted thing. We always encourage people to come back if they are getting recurrent problems with vomiting. With that, our rate of having to reoperate on people because of this slippage is under 2%. The most feared complication with the gastric band, though, is erosion. With erosion, the band slowly winds its way through the gastric wall and ends up on the inside of the stomach, and it is of no use there, and we've actually got to remove it and start all over again. Fortunately, the rate is under 1%, and it is not something that we know how to avoid. We just have to accept that there is this very small number of patients who will have a problem with it. So everything I've said probably still makes you very keen to go and do something about the weight loss, but the thing that does concern me is that we get hugely variable results. Take another look at the graph that I showed you before. With this graph, you can see that there is actually the same weight loss, but now we've put in the variation, in other words, the extremes of how much people lose. You can see with the gastric bypass that everyone loses something, but there's still a range from 40% of excess weight down to 100% of excess weight. With the band, there is actually the potential to lose no weight if people don't want to work with it. And therefore we have a huge range from 100% to 0% of weight loss. Therefore the bypass and the sleeve have definitely got a greater chance of giving you what you want. This of course raises the question, why does this occur? This comes back to what I mentioned earlier on about the pleasure center and the fact that you can release endorphins to self-medicate the problems in life. What actually got you big? It was those things that I've talked about, but it's also the way you live your life. It's the people around you that tempt you. It's the mother that bakes the beautiful cakes. It's the fact that you live in a place where you can't easily exercise in winter. It's who you socialize with, whether it's always coffee and cake. So many factors have joined together to get you big. We're just doing an operation on your stomach. We haven't changed any of those other things. For you to get a good long-term result, you've got to be able to change those other factors in your life. Why wouldn't you? Because you may not know how to. And that is the extra process that I talked about at the beginning. We realize that if we take away your ability to eat, but we don't give you other ways to cope with life and teach you that there are other healthy adult ways to deal with stresses, then of course you'll go back as soon as you can to using food to self-medicate those problems. So for that reason, we have a team of people, and that team includes psychologists to help you learn better ways to cope with the stresses. We've got exercise physiologists to help you find the exercise that suits you. Not everyone likes the gym, and whatever exercise you decide to do, you've got to be able to see yourself doing it in 5 years' time, because the changes you make have to be forever. The other really important thing is you still need endorphins in life. There's got to be a joy as you lose the weight. And you've got to find other things that do it for you that aren't illegal or moral or they make you fat. That is your job. I hope you realize from what I've been saying that I never blame my patients for being where they are. All these neurophysiological factors, their metabolism, the society that we have grown up in has led almost inevitably to people being overweight. However, after the surgery, I do hold people responsible for where they end up, because we will give every tool that we can to you, every strategy, and it really is up to you to utilize everything to produce the result that you want. If you decide that obesity surgery is for you, you've read through all the information and are prepared to make the commitment to make the change, then we would prefer you to see your general practitioner and ask them to do a referral through to us. We will then see you, put you through an education process, and then we're able to decide with you what operation is appropriate for you. There are some requirements for the surgery. First of all, you do have to have a BMI of 30 at least, and we prefer a BMI of 35 if you don't have any major medical problems. You need to have been overweight for a reasonable amount of time and have tried the simple diet and exercise measures and show that they haven't worked for you. It's also really important that you don't have any other addictions, and in particular alcohol and drug addictions. The reason for this is if we take away your ability to self-medicate with food, the natural inclination of the brain is just to go to the next addiction, and we have created alcoholics. So if you do feel that you enjoy the alcohol a bit too much or are aware that you are drinking heavily, we probably won't say no, but we would require that you put some processes in place to support you over the time of the surgery so that we don't head down that route. The cost is obviously an important issue. The way that we work it is we have a comprehensive preoperative assessment and education process. At this, you see the nurse and get educated. You see me and I check that you're medically okay to go ahead with the surgery. You see the nutritionist who explains to you what this new diet is going to look like and how you eat. And you see the psychologist so that he can see whether there are any major problems already that we might need to be working on sooner rather than later. The way the package works is that we cover the whole of the hospital costs, including the anaesthetist, the surgeon, the theatre time, and the band or the staples. We also charge up front for the 2 years of follow-up. The reason for that is we know that if people have regular follow-up, they're much more likely to get good long-term results. If you've paid up front, you're much more likely to actually utilize all the services that we offer because you want to get your money's worth. Here you can see the costs of the operations. Just because an operation costs more doesn't mean it's a better operation. It just means that the equipment is more expensive. In the end, you and I will decide between us what is the appropriate operation for you. I hope you found the information on this video useful. It's really important to us that we only be operating on people that understand and are on the same wavelength with us. You have to understand that this is a tool to help you to help yourself. It doesn't fix you. It is a way for you to be able to gain control of your life again with our help, but we have no control over how much you're going to utilize it. You need to be committed. You need to be sure that you are prepared to give up your old way of living. If so, contact us.